So I will invite our next speaker, Dr. David Hsu, to the podium. He's going to continue our discussion on GI malignancies with an update in colon cancer. Dr. Hsu comes from Duke Cancer Institute, where he is a clinician and researcher in the GI Medical Oncology Division.
Thank you. So I'd like to first thank OneOncology for inviting me to come give a talk today. So I'm going to talk about colorectal cancer. And so here are my disclosures. And I was told I had 20 minutes to talk about colorectal cancer, and that's definitely not enough time. So I try to figure out what's the best way to give this talk to try to cover what's clinically relevant. And so what I decided is I'm going to focus on 3 studies that has been presented either at ASCO this year or at ESMO to kind of highlight what kind of things we are doing in the treatment of colorectal cancer, what's kind of practicing changing, and things we should think about moving forward. So I'm going to cover 2 trials in a metastatic setting, and one is the Paradigm study, which was presented at the plenary session in ASCO to ask the question, what should we do about a right-sided versus left-sided colon cancer? Then I'm going to talk about a study that was presented at ESMO, which is a Mountaineer study, and this is going to focus on kind of what we've been hearing earlier this morning about actionable alteration, next-gen sequencing, and how do we personalize medicine in colorectal cancer. Then, kind of similar to what we also talked about this morning in sequencing, I'm going to talk about a study that was presented at ASCO, the Dynamic trial, which is for stage 2 cancer. And we kind of have talked about this earlier this morning about circulating tumor DNA, when to use it, et cetera. And so we're going to talk about the Dynamic trial in the context of stage 2 colorectal cancer. So let's talk about the first study, okay? So I'm gonna take you guys back to embryology. Remember in med school, we talked a little bit about embryology. We all forgot it and never realized it was gonna be important again. But remember, the colon comes from 2 different parts of the embryonical origin. The right side, it comes from the midgut, and the left side comes from the hindgut. So if you think about that in the biology, they should be slightly different. So even though in practice we've been treating them all the same, the question is biologically, are they different, and should we consider them different entities? So in fact, if you actually look at sequencing tumor profiling, they are different. On the right side, we tend to see more BRAF mutation, a little bit more KRAS mutation, a little bit more MSI, high tumors with a decrease in epiregulin. And on the left side, we tend to see more HER2 amplification, less MSI with an increased regulation in epiregulin. So you can see anatomically, this kind of confirms what we know in embryology, that the left side is slightly different from the right side. Now, how does that go into how we do practice today? Well, for the longest time in colorectal cancer, everybody knew that FOLFOX, FOLFIRI, OX, ERI were all the same, right? An initial study backed by Turnergaard back in 2004 showed they're equivalent. So for the next decade, we were all trying to figure out, well, what targeted agent should we combine with it? And for colorectal, we have 2, anti-VEGF and anti-EGFR. So there was 3 trials that came out. The CLGB was actually a plenary session at ASCO about 4 years ago, which all asked the question, what anti-VEGF or anti-EGFR, which targeted agent should we combine with chemotherapy? So you have the FIRE3 trial, the PEAK trial, and the CLGB 80404 trial. And essentially, the bottom line is when you look at these trials, it came to the conclusion that either any chemotherapy backbone, you can combine either an anti-EGFR or anti-VEGF, which is fine, but then clinicians, researchers try to ask the question, well, if the left side and right side are different, shouldn't we consider potentially there be different response to treatment? So we started looking at the subset of the CLGB, PEAK, and FIRE3 trials, and we kind of looked at left-sided versus right side. And if you look at these 3 studies, what you did notice is that if you're a left-sided tumor, these are, remember, all KRAS wild type because we're looking at anti-EGFR versus anti-VEGF. If you're a left-sided tumor, you had a significant better outcome if you get an anti-EGFR therapy. Now, we're not talking 1 to 2 months, right? If it was 1 to 2 months, we probably wouldn't care as much. But the difference we were seeing was 8 to 10 month difference. Now, if you look at the right side, the opposite seemed true, that if you get anti-VEGF therapy, you actually get 4 to 5 month difference. Now, interesting enough, when I took my boards 3 years ago, recertification, this was a question actually on the boards. So even without any phase 3 randomized trial, this was already showing at the board. So I would say that most of us, based on these studies, have been practicing that if you have a left-sided tumor and you're RAS wild type, we should be given an anti-EGFR. And if you're right side, this suggests you should get anti-VEGF. But again, we practice evidence-based medicine, so what's the data? So this finally came out at ASCO, and it was a paradigm trial. It was a Japanese style, but it asked the question, FOLFOX versus combination of PMAB versus bevacizumab in a phase 3 randomized trial. So this was a trial design. This was newly diagnosed unresectable colorectal cancer patient, wild type, and they were randomized either to FOLFOX with PMAB or FOLFOX with bevacizumab. The primary endpoint was they first looked at overall survival in the left-sided population. If that was met, then looked at overall survival in the overall population. So the question again here is there a difference, or should we be given anti-EGFR or anti-VEGF in this setting? So if you look at progression-free survival, which is not the primary endpoint, but the secondary endpoint, what you notice is there's absolutely no difference, right? So this would suggest that initially, if you give either anti-VEGF or anti-EGFR, the clinical outcomes or the time on treatment is the same because progression-free survival is the same. But the question is, what happened to overall survival? If you look at this graph, you clearly see for patients with left side, if you get an anti-EGFR therapy, you have significantly improved overall survival of about 4 to 5 months. Now, this is slightly smaller than the subgroup analysis of all the phase 3 trial, but 4 or 5 months in a randomized trial was significant, and this suggests that even though the initial therapy may be the same, what you get afterward is more critical, and because of that leads to overall survival benefit. Now, this is left-sided. So remember, the trial of this design was if there was positivity in the left side, what's the overall survival? So again, if you look at overall survival, there also appears to be a benefit overall in using an anti-EGFR therapy. Now, how about the right side? Interesting enough, if you look at the right side, remember, in the PEAK, FIRE3, CLGB, it appeared that right-sided patient benefit more from an anti-VEGF. In this randomized phase 3, if you actually look at the data, there appears to be no difference. So at least in this setting, we are not seeing the difference in anti-VEGF that we did with the subgroup analysis. So where does that kind of leave us? With the paradigm trial, what it showed was that the addition of PMAB as first-line treatment for metastatic colorectal demonstrated superior oversight in left-sided and overall population. Progression-free survival appeared to be comparable, like I talked about. They also looked at response in R0 resection, and that was higher in the panitumumab arm than the bevacizumab. And so the investigators concluded that for patients with wild-type RAS and left-sided metastatic colorectal, FOLFOX plus panitumumab or anti-EGFR is supported in the first-line setting. So pretty much what we knew before, but at least now we have evidence-based medicine and a randomized phase 3 to document how we treat. So let's look at the second study. So what I want to talk to next is about targeted agent. So this was presented at ESMO by my colleague, Dr. Strickler, and it was a Mountaineer study, which is a phase 2 study of tucatinib and trastuzumab for HER2-positive metastatic colorectal cancer. Now, why study this? Now, HER2 amplification doesn't occur as much as breast cancer, like we know, but it does occur in colorectal cancer at about 3 to 5%. And we know that patient with HER2 metastatic colorectal cancer who progresses on chemo, we actually don't know what to do, what to give them, or if they should get anti-HER2 therapy. So this trial was selected to look at tucatinib, which is highly selective for HER2 with minimal inhibitory effect on EGFR. So the goal of the Mountaineer trial was to evaluate the efficacy and safety of the combination of tucatinib and trastuzumab in patients with HER2-positive and RAS wild-type colorectal. So this is a study design. So one key point I want to talk about the study design and the eligibility is that this was for patients who's progressed on 2 lines of therapy, okay? And this is going to become very important because if you think of patients who progress on 2 lines, we're talking about refractory patients, right? Patients who progressed on OX or ERI, and we're talking either Lonsurf or regorafenib, and we know in those settings, time on treatment, progression-free survival is about 1.9 months, and overall survival about 5-6 months, right? So keep those things in mind when we talk about the Mountaineer study. So initially there was a cohort A, which was just patient that was just getting tucatinib and trastuzumab, and because of early signal, it was expanded to a randomized trial of tucatinib plus trastuzumab versus tucatinib alone. So this is a change in tumor size. So remember in the recourse or the correct trial, the overall response rate was about 5 to 10%. Stable disease was over 40%. In this study, we showed that the tumor burden, reduction in tumor burden was 65%. Again, in the refractory patient, we saw a lot higher response rate than we do with the current standard of care. If you look at progression-free survival and overall survival, again, remember in the recourse and the correct trial, the progression-free survival was approximately 1.9 months. In this heavily treated population, we saw a progression-free survival of 8.2 months. In the overall survival, correct, recourse was about 5-6 months. Here, we saw 24.1 months. So this clearly shows that if we're able to identify patients who will respond based on molecular profiling or personalized medicine, there is a significant benefit. So safety is always important because we're talking about a patient in the refractory who's been beat up by the chemotherapy. If you look at the safety, look at the two bottom ones, AEs leading to study discontinuation, only 5%. Death due to AE, 0%. And if you look at the AEs, diarrhea is most common, 50% grade 1, 10.5% grade 2, but this was very well controlled. Hepatotoxicity, only 3.5, 2 to 3% increase in grade 3 of ALT to AST. Cardiotoxicity, very limiting. So I think this is very important, right? Because when you talk about the third-line refractory setting, we always talk about disease control versus quality of life, right? We all given regorafenib. It's a hard drug to give, okay? Lonsurf is slightly easier, but regorafenib with its rash, et cetera, fatigue is hard to give. So it is important that in this setting, there's potentially a targeted agent that has very few or minimal side effects and toxicity. Now, in fact, one of my patients was on this trial. He actually had the highest HER2 amplification I've seen. His HER2 to CEP ratio was greater than 10, which is very high. He is currently still on trial, and he's been on trial for over 3 months. I mean, currently over 3 years. So he's like the longest patient on this Mountaineer trial, and he's essentially leading a normal life. So again, this shows the importance of molecular profiling, that if you select the right patient population with the right target, we can achieve significant clinical outcome. So in conclusion, chemotherapy refractory patient, tucatinib in combination with trastuzumab demonstrated doable and clinical meaningful response, was very well tolerated, and this has could potentially become a new standard for care for patient with HER2 metastatic colorectal cancer. Now, in fact, this was in the refractory setting. There is now a global randomized phase 3 in the first-line setting. So, and the other thing I learned from Dr. Strickler is the combination tucatinib trastuzumab is going through FDA, and there could be approval as early next year. So we don't have to worry about putting patients on this trial because this could soon become standard of care. Now, the last thing I want to talk about is circulating tumor DNA, which we heard about this morning. And specifically, I want to talk about the dynamic trial. And this was actually published in the New England Journal while going to ASCO. Now, why study this, right? As we heard before, circulating tumor DNA is tumor-derived fragment DNA in the bloodstream. Known as liquid biopsy, it can represent the entire tumor genome, and is currently being used to detect minimal residual disease. And so one of the questions we talked about here is what is the role of ctDNA in the adjuvant setting in resected colorectal? And specifically, I want to talk about the stage 2, because as we know, stage 2 is the most difficult conversation we have with the patient. Stage 1 is easy, they don't get adjuvant. Stage 3 is easy, they get adjuvant. Stage 2, the question is, what is the benefit of adjuvant? And is there something we can use to help guide therapy? So the dynamics trial was used to answer that question on whether or not circulating tumor DNA can help us. And so these are all stage 2 patients, and after resection, week 4 and 7 post-op, they got their blood drawn and they got ctDNA. And they were randomized into 2 arms. One was a CT-guided management, where if you are ctDNA positive, you got adjuvant chemo. If you're ctDNA negative, you got observation. And that was randomized to just standard of care management that we would assess risk of recurrence in the stage 2 and decide whether or not patient should get adjuvant therapy or not. So let's look at the data. So this is the data first looking at not if we were to guide them, but looking at what happens if you're ctDNA positive versus negative. So as expected, if you're ctDNA negative, your outcome is great, 92.5%. If your ctDNA is positive, your prognosis is much poorer. It's at 86.4%. So this kind of confirms what we know, that if you have positive ctDNA, your prognosis is poorer than if you have negative. Now, what should we do about this? Interesting enough, if you look at recurrence-free survival, right, meaning if you had positive ctDNA and you got adjuvant versus us deciding whether or not patient get adjuvant, there was no difference, right? The recurrence-free survival was the same, 92.4% versus 91%. So this suggests that whether we use ctDNA or not in our practice, the outcome was the same. Well, what's the difference? The difference was how many people got adjuvant chemotherapy. So if you look at this, if we use standard of care, patients tend to get more adjuvant chemo, right? So if you look at the first line with standard management, 28% of stage 2 patient got adjuvant chemotherapy. If you're ctDNA guided, only 15%. So twice as many patients potentially got unnecessary adjuvant chemotherapy without the use of CT-guided DNA. Now, interesting enough, if you kind of look at what chemo they got, in the ctDNA guided therapy, 62% got OS, because the assumption is if you have positive ctDNA, MRD, you need to treat more aggressively, kind of our high-risk stage 2. For the standard of care management, interesting enough, most patients got just 5-FU-based therapy, right? So only 10% got OX, 90% got 5-FU, which shows that we tend to like to treat patients with adjuvant therapy to make sure that we maximize their risk of recurrence, but we're also very conscious about OX-based neuropathy, and we tend to use 5-FU more in the stage 2 setting. Now, if you actually look at who benefits, I think this is interesting, because if you have ctDNA positive and you have high-risk feature, specifically T4 stage, there seems to be little benefit in using CTA to guide therapy. Meaning, if you have a T4 disease, and clinically we know these are high risk, and we give adjuvant therapy, they do just as well as if you knew whether or not they were ctDNA or positive. So this is very important because it kind of asks the question, when should we use this test? So if you think about this dynamic style, in conclusion, it says for patient with stage 2 colorectal cancer, a ctDNA guided approach compared to non-guided approach reduces the proportion of patient receiving adjuvant, 28% down to 15%. Recurrence-free survival was the same in both arms. ctDNA negative patients have a low recurrence without adjuvant. High-risk patients may not benefit from ctDNA test. So what does this mean? What do I do? So there still needs to be more data collected, but in my practice, if you have a stage 2 patient with T4 disease or high risk, I don't think a ctDNA is going to help change my mind that they shouldn't get adjuvant. So if a patient has a high risk T4, I still offer them adjuvant, or I have the adjuvant talk with them. I think the ctDNA is more useful in patients who are T3 and 0, where the risk of recurrence in this stage 2 patient is anywhere from 10 to 15%, and the benefit of adjuvant therapy is a relative risk reduction of about 2 to 3% when we talk to them. So right now, the way I use ctDNA in my practice is if I see a low-risk ctDNA, low-risk stage 2 patient, T3 and 0, where I'm unclear whether or not they would benefit from adjuvant therapy, this is where I use ctDNA to help me guide therapy in the adjuvant. For high-risk stage 2, T4, I don't use ctDNA yet because I need more data, but I feel those patients really need adjuvant chemo because remember, if you're T4, you're essentially stage 2C, 2B, or TC, which actually has worse prognosis than a stage 3A patient. So this is kind of where ctDNA is going. Still a lot of work to need to be done, but it is I shouldn't say on the horizon, it is in the horizon because we are using it and more data will come out. So with that, I'll stop. Looks like I got a minute left and welcome any questions. Thank you.
I have a couple of questions. Could you comment on different platforms for ctDNA?
Yeah.
And
good.
second question is, if we believe in MRD, would we be ready to give it a try for stage 3A? And if it's MRD negative, avoid chemo?
Yeah, good question. So let me address the first question first. So when you talk about MRD and using this ctDNA, there are two types, right? There are tumor-specific and tumor-agnostic. The tumor-specific is typically Natera, the Signatera test. Tumor-agnostic is Guardant, which probably has a lot. So the difference is if you're tumor specific, what Signatera does is they have a proprietary, they'll take your tumor, they'll sequence it, and they determine 20 hotspots in your tumor. Then when they do circulating tumor DNA, then they look for those hotspots to see if they're present, and that's how they calculate it. Now this is actually very important because with a tumor specific, you actually need to sequence the tumor, which means that the initial Signatera test takes 4 to 6 weeks, right? So if you look at the original data from Signatera, you have to get your sequencing tumor. They typically collect in their first trial about 6 to 8 weeks. So if you're collecting at 6 to 8 weeks, then you're waiting another 4 to 6 weeks to get data. Guess what? You're like 12, 14 weeks after surgery. And we know that there's data suggests that if every 4-week delay in adjuvant therapy after resect the colorectal cancer, you lose approximately 4% absolute risk of recurrence. So it is a little problem with the tumor specific, but I do think it's a better test. They've done more samples, but their sensitivity and specificity is much higher. Guardant, a little different. It's methylation, similar to the Grail. And with methylation, you don't have to sequence the tumor. That's why it's tumor agnostic. And Guardant, as you guys all know, you get it back within a week. Guardant hasn't done as much tests as a Signatera. They don't have the patient volume yet. However, their sensitivity and specificity currently looks much lower than the Natera. However, they just don't have the volume. Currently, what do I use? I use a Signatera because I do think tumor specific is potentially has higher sensitivity and specificity, but more data needs to be done. So that was a long-winded answer. What was your second question? I'm sorry. Oh, yeah, stage 3. Yeah. So that's a good question. Interesting enough, I've given a lot of GI debates with this question, and I've gone through all the Signatera tests. So the question in stage 3 is, number 1, do they need it? And number 2, can we keep them from getting oxaliplatin-based therapy, which, as you guys know, can cause life-threatening neuropathy? A lot more study needs to be done. Right now, I don't use it in the stage 3 setting unless there is a concern or concern that there may be more harm in the adjuvant setting. So if I see a patient, who somehow got through 3rd surgery, but they're on dialysis with heart failure, do I really want to give them adjuvant therapy? So I will do it in specific cases when I feel that adjuvant therapy could potentially cause more harm than benefit. But right now, my standard practice is not to use it quite yet in the stage 3 setting.